Hello everyone, this study comes from Seoul, Korea, discussing the influence of an isthmus on the outcomes of surgically treated molars in a retrospective study design. Starting things off with the definition of an isthmus, which is a narrow, ribbon-shaped communication between two root canals that contains pulp tissue, and it is also known as a corridor or a transverse anastomosis. Many anatomic studies have reported on the incidence of isthmus, with the reported incidence in the mesobuccal root of maxillary first molars ranging from 76% to 100%, and for the mesial root system of mandibular first molars to approximately 83%. And to this date, it is difficult to perform direct mechanical preparation and chemical disinfection, and there is no perfect method for cleaning and shaping of an isthmus yet has been devised. This would pose a layer of difficulty in root canal treatment, which an isthmus might contain necrotic debris and also tissue remnants that can be shelter for bacteria to grow and multiply, ultimately causing failure of the surgical or non-surgical root canal treatment. There are 5 types of isthmus configuration according to Su and Kim, and type 1 isthmus was defined as having either 2 or 3 canals with no noticeable communication, and type 2 and 3 contain 2 to 3 canals respectively, each having a definite communication between the main canals to the secondary canals. And type 4 isthmus has canals that extend into an isthmus area. Type 5 was recognized as a connection throughout the section, which would provide a ribbon-shaped canal. For the methodology of the study, cases with a history of endodontic microsurgery between July 2001 and May 2014 were selected. The same surgeon performed all surgical procedures using a surgical operating microscope. The apical 3 mm root tip with 0 to 10 degree bevel was amputated, and the resected surface was dyed with methylene blue and inspected using a micromirror under high magnification of 20x to 26x. Whenever an isthmus was observed after staining with methylene blue, it was prepared along with the main canals, and whenever it was not detected, only the main canals were prepared using the ultrasonic tips and filled with either ProRoot MTA or Super EBA. Follow-up records at each visit were taken for signs and symptoms of tenderness related to percussion, mobility, periodontal pocket formation, sinus tract formation, or any subjective discomfort were evaluated, and also periapical radiographs were exposed and taken from 3 different horizontal. A total of 106 teeth were included in the study. 72 were teeth with an isthmus and 34 were without. And only 27 teeth were categorized as failures and 79 teeth were successfully treated. 24 out of 27 failures had underwent isthmus preparation, whereas only 3 did not have an isthmus preparation. The analysis revealed that cumulative survival rate after surgery was 61% after 4 years when an isthmus was present and prepared, and the survival rate after 4 years was 87% when an isthmus was absent and unprepared, which was significantly higher than that of an isthmus present teeth. Multivariate Cox proportional hazards regression analysis was done, and it showed that the adjusted hazard ratio for failure was 6 times higher for the isthmus present teeth, which were prepared, than for the isthmus absent teeth. Although age and sex influenced outcomes, the jaw and root end filling materials exerted no influence. Now, the results of this study are contradicting with previous work by Willer et al. And Teixeira et al. That suggested that when 2 canals are present in the same root without the determination of the presence of an isthmus via staining, the presence of an isthmus should be expected and prepared even though it was not detected clinically. Stropko et al. Also suggested that when no evidence of isthmus was observed, there was a good possibility that one would be present immediately underneath the surface of the resected root and raised the need to always prepare an isthmus where there are 2 or more canals in the root. However, the present study found that the 4-year success rate was relatively high, 87%, in teeth with no isthmuses detected, and thus were unprepared. It was also as high as 87% in the anterior teeth reported by other studies, and these findings suggest that no additional preparation should be necessary for a type 1 isthmus with no observed communication.